Switching gears from brain to the heart, we are going to talk about how ECD and the treatments affect the heart. I'm very pleased to invite Dr. Carrie Lanneman, who is a professor of cardiovascular medicine. We have a special clinic led by her. The program is cardio-oncology program, and her clinic's focus is especially on trying to figure out how the disease affects the heart, cardiovascular system, how treatments affect them, and how people can have a healthy cardiovascular status. So I'm very grateful to have her collaboration on all my complex cases or any issues that come up. And I would like to invite her now to share her thoughts about this topic.
Great. Thank you for this opportunity. I'm excited to share with you a little bit about ECD in the heart, some of the stuff we may know, but also, advanced slide. Am I doing that? Maybe. Oh, okay, I'm technically challenged. Sorry about that. Okay, forward. If I just did the forward, we're all good. Sorry about that. The monitor's not on. Okay. So I thought we'd first review common issues that affect the heart as it relates to ECD, and how should we look for ECD in the heart, and what are the potential side effects of the treatments that we've heard a lot about this morning, and how we can work to protect and monitor the heart more closely. And lastly, we'll talk about monitoring strategies that we recommend for patients. So before we get started or too far along, I thought we would talk a little bit about heart anatomy. Let's see if I have a pointer. Yes, great. We have a pointer. Thought we'd talk about the heart because we'll look at some pictures. And we think about ECD and where it can affect the heart. We talk about the atria. The heart obviously has two top chambers. These are called the atria. A lot of our electrical conduction begins here in the atria, and we'll go down and go through the ventricles, and we'll talk about why that matters. And also, we will talk about the heart actually sits in a sac, in a little fibrous sac called the pericardium. And that's important because our pericardium has a little bit of fluid in it, but in some cases in ECD, there can be more fluid in the heart, and that can cause complications like tamponade, and I'll discuss that further. So heart involvement's not uncommon in ECD patients. Data shows it can be anywhere from 40 to 60% of patients. One of the most common areas where ECD will affect the heart is this atrial infiltration. It'll actually be noted in the top chambers, those atria. They'll see pericardial thickening and even sometimes fluid that will actually accumulate around the heart. Not only can it actually be in the heart, it can actually be in the blood vessels called the coronary arteries that actually feed the heart, as well as in the aorta. Cardiac MRI, hands down, is the most sensitive way to look for ECD in the heart, and I'll show some good pictures of that. And cardiac involvement is present in about 48% of patients that have the BRAF mutation. So what are the effects of ECD on the heart? Some people can be asymptomatic, if you can believe that. People can be asymptomatic with cardiac involvement. Some people, as I mentioned, some people can actually, as I mentioned, because the sac that the heart sits in can have something called pericarditis, which is a fancy word for meaning that sac the heart sits in becomes inflamed and irritated, and they may have a little bit of chest discomfort, especially when they're taking breaths or having movement positions. They can also have what is called tamponade, and I'll show a picture of that, of where fluid accumulates in the heart and actually is compressing these chambers, not allowing the heart to fill. Some cases, patients may have heart failure, and in some rare cases can have, when there's infiltration in the coronaries, can have presentation of an MI, which is a myocardial infarction, or a lack of or decreased blood flow to the heart. So let's talk about some show and tell. These are some examples of cardiac MRI where it shows that there is atrial infiltration. Remember, these are the top chambers, and you can see the ECD histiocytes infiltration in the top chamber. This is still within the top chamber, but it's between the top two chambers. It's called atrial infiltration. Down here, we show the pericardial infiltration. In this slide, pane 8, we see that there's pericardial fluid, a significant amount of fluid here. And in this picture here, we see that the fluid is becoming more significant, and in some cases it may even compress the right side of the heart, the right atrium and the right ventricle from being able to fill, and that's what we call tamponade. A rare presentation, but you may have symptoms of shortness of breath and swelling and fluid building up. So those are things to be aware of. Like I said, rare, 5% or probably even less is what's reported. And this is just a picture of a coated aorta where we're seeing ECD histiocytes actually infiltrating the blood vessels there. So what to do, or, what would happen if your heart is involved? Like I said, some people can actually be asymptomatic, but as I mentioned, they can have some heart rhythm problems, because as I mentioned, the wiring of the heart actually begins in those top chambers and goes throughout the bottom chambers, the ventricle. So they can have some heart rhythm things such as atrial fibrillation or extra heartbeats called premature beats that can occur. So people can feel some palpitations occasionally or have dizziness. They can, like I mentioned, have that pericarditis, the inflammation of the heart sac, tamponade where the heart is compressed, and as I said, rare causes, but they can actually have a heart blockage because there's infiltration actually in the coronary artery, which is the arteries that actually are going to the heart. And again, it can cause some shortness of breath, some swelling, so if you're having concerning cardiac symptoms, obviously go to your doctor, or if it's severe, go to the emergency room. Targeted therapy, as we've heard from our good friend Daniel, we've heard a lot about BRAF and MEK inhibitors, but they are obviously one of the first line of treatments for those patients that may have cardiac involvement that have significantly improved prognosis, which previously was quite poor with ECD and cardiac involvement. This is just a little study to kind of show, fairly recent in 2023, where they had 200 patients from a center that had ECD and were followed over 5.5 years. Because their main question is, those that have heart involvement, did that affect their mortality? And interesting, of these 200 patients, 96 of them had cardiac involvement. As you can see, atrial infiltration was most common, pericardial involvement was the second most common. The interesting thing is that even those that had cardiac involvement, that luckily did not affect survival. It might have made them a little higher risk for some clinical events to have some of those problems we talked about, the inflammation of the heart muscle, the fluid that can occur, and the conduction problems, the electrical problems. But luckily, it did not affect their overall survival. And as we mentioned, a lot of these individuals that had cardiac involvement had that BRAF mutation. So treatment options, I will quickly just kind of mention this. You guys have gotten kind of beat over the head about BRAF and MEK inhibitors, but why would a cardiologist care about this? Is because it has some effects on the heart that are really important. BRAF inhibitors will talk about the QT involvement, and then the MEK inhibitors will talk about not only QT, but also look at following the cardiac function over time with that. And you guys have really heard a lot about what is BRAF and MEK inhibitors. Know that these are obviously targeted treatments. They can obviously be used in ECD, but they can be used for other oncology issues like melanoma, non-small cell lung cancer, and certain forms of thyroid cancer. And as we say, targeting these pathways obviously helps people with ECD, but you got to think these pathways also exist in normal cells, in normal cardiac muscle cells. And that's why, unfortunately, there can be some off-target, some unintentional effects of the cardiac myocytes in the vasculature. And so you can see if we are blocking these pathways that are present in even normal cells like cardiac cells, that we can interfere with normal cell repair and homeostasis. So sometimes in some cases our heart muscles, the cells aren't having their normal cellular pathway that are important for repair. And that's just a quick sort of depiction. Again, maybe these are the pathways we're targeting with BRAF and MEK inhibitors, but these pathways are also present in cardiac myocytes and within our vasculature. So sometimes, in some cases, we'll see some off-target effects, and that can be some issues that we'll look at. So what are the potential effects of these therapies on the heart? The most common thing that we see is hypertension. So having patients know how to check their blood pressure, knowing what normal blood pressure numbers are really important, because guess what? We can treat blood pressure and we can keep you heart healthy by treating that blood pressure. Secondly, they can also have a lot of peripheral edema. And again, a lot of the medicines we might use to treat blood pressure can also help with the peripheral edema and swelling. The other important thing that we look for, that the range is varied in the literature, but patients can develop LV dysfunction, a fancy word for that. The pumping percentage may actually decrease in patients. And in some patients, some rare cases, patients can develop congestive heart failure where their heart has a hard time keeping up with all the fluid. Excuse me, sorry, I'm having a hard time with the pointer. Other things we'll talk about more electrical related are AFib and QT prolongation, and then clotting issues. Patients can present with blood clots to the lungs called pulmonary embolus, or they can get blood clots in their legs called venous thromboembolus. So let's talk a little bit about the EKG that patients may come in and get frequent EKGs, and that's what Dan was alluding to, this QTc monitoring that he was saying. And what we're looking for, not that you need to know how to read your own QTc or anything, because that's there's a little bit of art and science to it. But if you're looking on the EKG where the upward deflection where this little what's called T wave ends, that's called your QT. And around 380 is very normal. As you get above 500, it becomes abnormal. So what we're looking for are significant changes. And these drugs, unfortunately, sometimes can prolong that QT interval, and that can cause patients to have some palpitations, feel dizzy if it were to become really prolonged. And the important thing to also note is that if you get prescribed a new nausea medicine, a new antibiotic, a new antidepressant, you may want to talk with your physician and also maybe even your pharmacist and say, hey, remember, I'm on this drug and they're monitoring something on my EKG. Can you make sure these drugs are okay? And also, again, if you get a new antibiotic, you may want to talk to your oncologist about who's prescribing your MEK or your BRAF inhibitor and say, hey, I got put on this. Do I need to come in and get an EKG at some point? So what else do we need to think about doing for individuals who are on these drugs to sort of monitor and keep their heart healthy and safe? And as we mentioned, it's really important to keep your blood pressure well controlled. So we usually have patients have a blood pressure cuff and check their blood pressure about every 4 weeks, baseline, and then every 4 weeks, just to make sure that blood pressure is not rising. And our goal is under 130/80 is sort of a blood pressure goal. We also want to get a baseline echocardiogram, and that's where we're really looking at that heart function, that pumping percentage, that ejection fraction. You may hear those words being used by your physician. So we're looking at that at baseline, 1 month, and 3 months after while you're on therapy, just to make sure that that ejection fraction is staying stable. And then again, EKG, usually baseline and then 4 weeks. And then with any dose escalation, or again, as I would emphasize, if you get put on a new antibiotic or get prescribed an anti-nausea medicine that you're going to have to take very regularly, or a new antidepressant, you may want to touch base with your provider and let them know that you got put on those so that they can monitor that QTc that we're talking about. Lastly, a couple of slides about just general heart health and what is really important. And, I spend a lot of time with my patients counseling them about healthy lifestyle habits. And one thing I want to kind of sort of promote, if anyone has some interest in overall heart health, there is a patient-centered website called CardioSmart. So you can just Google CardioSmart. It's got some great educational tools and patient handouts. This is one I give a lot in my clinic, just about, what are some good diets? And these diets that I'm talking about are Mediterranean, a plant-based diet, or DASH diets. Those are all really good heart-healthy diets. And a lot of the main focuses of these diets are fresh fruits, vegetables, healthy, lean fats, whole grains to increase our fiber intake, and lean proteins. So again, I really would suggest CardioSmart's a great place to look. These 3 diets are the diets I think are most important, and the evidence shows that these are the diets that keep us heart healthy. And lastly, physical activity. Dan kind of alluded to this about how do we keep our patients moving and staying active, because exercise is so important. It's important to help keep our heart muscle strong. It helps lower our risk of stroke and heart attack as much as 20 to 40%, helps lower blood pressure, improve cholesterol. It's important for controlling our blood sugar. And obviously, the important effects, it boosts our mood. It helps reduce stress and inflammation. So, I don't tell my patients, oh, you got to go work out for 30 minutes every day. That's not realistic for our patients because of different limitations, because of time constraints. There is more and more data now showing that even if a patient can go do, a 5-minute walk several times a day or a 10-minute walk 3 times a day, that is just as good as doing a 30-minute walking exercise. So you don't have to carve out huge amounts of time to have exercise. So again, staying active as much as you can, as Dan was saying, maybe early in the morning when you have the most energy or after a nap, to sort of encourage, movement and activity. The physical activity recommendations are 150 minutes per week. So that's not in a day, 150 minutes per week. And that includes doing your normal activities. So maybe if you're out in the yard doing a little gardening, that still counts because you're moving. And also the physical activity guidelines also recommended 2 days a week of strength training. And that doesn't mean having to go to a Planet Fitness and, get big barbells or anything like that. I mean, it could be simple, chair, sit, stand. It could be some yoga. It could be anything that's helping keeping your muscles stay strong. So I think that may be my last slide. Oh, take-home points. Okay. Remember, heart involvement in ECD is common, maybe around 50%. Most commonly found in the atria and the pericardium. A cardiac MRI is a really helpful tool, especially to get a baseline to kind of see if there is heart involvement and where it is located, and that these targeted treatments are common and they can have some cardiac effects, but we can mitigate that with really good, collaboration and controlling blood pressure, monitoring your heart, and helping everyone have a heart-healthy lifestyle. And with that, I will say thank you, guys. Thanks for your time. I'll take any questions.